Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing a very important topic, very high yield, not only for postgraduates as well as undergraduates, and that is chronic otitis media, which used to be also known as chronic suppurative otitis media or CSOM. Now you can also purchase my notes. I have added links in the description. So let's get started. Now, what is chronic otitis media? Chronic otitis media is basically chronic inflammation of a part or whole of the middle ear cleft, and it is characterized by ear discharge and permanent perforation of the tympanic membrane. Now, what are the structures of the middle ear cleft? The middle ear cleft includes the middle ear cavity, eustachian tube, attic, adytus, antrum, and mastoid hair cells. Now, coming to epidemiology, chronic otitis media has a very high incidence in developing countries, and there are three reasons behind this. One is a poor socioeconomic standard in the developing countries, poor nutrition, and lack of health education in the people. So, these are the reasons why the incidence is higher in developing countries than in developed countries. And it seems to be that chronic otitis media is actually a leading cause of hearing impairment in the rural population. And this disease affects both the sexes and all the age groups. Next, we move on to classifying the disease. Now, there used to be an older classification where we used to divide chronic otitis media into the tubotympanic type, which was also known as the safe type, and the atticoantral type, which was known as the unsafe or the dangerous type. However, there is a new classification now. Now, you divide chronic otitis media into mucosal type and the squamosal type. The mucosal type in itself can be divided into active, inactive, and healed types, whereas squamosal disease can be divided into two. The active type is known as Cholesteatoma, and the inactive type is known as Retraction pocket. Now, I'll be discussing each of them in details. So, first, I'll start with the mucosal type of chronic otitis media. Now, mucosal type is the type which used to be earlier termed as tubotympanic disease or the safe or the benign disease. This disease basically involves the antero-inferior part of the middle ear cleft, which means it includes the eustachian tube and the mesotympanum. If you see in the image over here, this is the eustachian tube and the mesotympanum. So this is what is involved in the mucosal type. Now, the mucosal type has been divided into three different types: active, inactive, and healed. Now, what is active mucosal chronic otitis media? This is where you see a permanent defect of the pars tensa with an inflamed middle ear mucosa which produces mucopus that may discharge. Basically, when you examine the patient, at the time of examination, you will see a discharging ear. That is acute mucosal chronic otitis media. If you see the first image on the left side, you can see that this is active mucosal COM. This is on the left side. You can see that the middle ear mucosa is inflamed over here, and there is a permanent perforation of the tympanic membrane. Next, we come to inactive mucosal otitis media, chronic otitis media. Now, here you see a permanent perforation of the pars tensa, but the middle ear mucosa is not inflamed. So you see that there is no ear discharge for more than 6 months when you take history of the patient. This implies basically that a previously discharging ear has now become dry and will probably not resume discharging. That is when you term it as inactive mucosal chronic otitis media. If you see in the second image over here, you can see that the ear is completely dry, there is no discharge, and the middle ear mucosa also is not inflamed, but however, you do see a permanent perforation of the tympanic membrane. The third type is the healed chronic otitis media. Here, what happens is there is either thinning or localized or generalized opacification of the pars tensa without the presence of any perforation or retraction, or the formation of tympanosclerotic plaques. This basically means that this is a permanently controlled middle ear infection. It has healed, it has reached resolution. Here the pars tensa is definitely intact, however it will be abnormal. So if you see the third image over here, this one over here, this is showing a thinning of the tympanic membrane. You can see in this region that the tympanic membrane looks to be quite thin compared to the normal appearance of it. So this chronic otitis media has healed by a thinning of its tympanic membrane. Whereas on the right side, the fourth image over here, you can see there has been formation of some whitish chalk-like deposits on the tympanic membrane. These are known as tympanosclerotic plaques. So these are the three types of mucosal chronic otitis media. Next, we'll talk about the etiology of mucosal type of chronic otitis media. Usually, most commonly, it is seen that usually it arises from an episode of acute otitis media where after the rupture of the tympanic membrane, it fails to heal. That's when over time it leads to the formation of chronic otitis media. Secondly, permanent perforation can also result from cases where there is an insertion of ventilation tube in the tympanic membrane and after removal it fails to heal. That's when it leads to chronic otitis media. Other than that, other ascending infections via the eustachian tube can also lead to infection of the middle ear and can cause a persistent ear discharge. And these can be infections from the tonsils, adenoids, infected nose, and paranasal sinuses. And very, very, very rarely, food allergies may also cause a persistent mucoid otorrhea. However, the most important cause is usually the following an episode of acute otitis media which has failed to heal. Now, the microorganisms involved in this type are both aerobic as well as anaerobic. Aerobic organisms, the more common ones include Pseudomonas aeruginosa, Proteus, Escherichia coli, Staphylococcus aureus, whereas anaerobic ones are Bacteroides fragilis and anaerobic streptococci. Next, we'll talk about the pathology of the different types of mucosal chronic otitis media. First, coming to the inactive mucosal type. Here, it is characterized by a permanent perforation of the pars tensa. This is very important. Second important point is middle ear and mastoid are not inflamed, and this is what will differentiate from the active type. The mucocutaneous junction is usually located at the margin of the perforation, which can extend up to the fibrous annulus. So you see in the image over here, we can see a permanent perforation over here, and the middle ear mucosa is not at all inflamed. So this is the inactive mucosal type. Next, we'll talk about the different pathological changes that happens in the active mucosal type. First, we'll talk about middle ear mucosa because that's the thing that is differentiating from inactive mucosal type. So first you see that there is a chronic inflammation involved in the middle ear mucosa as well as the mucosa of the mastoid with varying degrees of edema, submucosal fibrosis, hypovascularity and inflammatory infiltrate, which includes lymphocytes, plasma cells and histiocytes. So basically, the middle ear mucosa, as you can see in the image over here, it appears kind of edematous and very velvety looking. It is very reddish and velvety. There is also an increase in the goblet cells and basal cell hyperplasia in the middle ear epithelium. Next is the formation of oral polyp and granulation tissue. If you see in the image over here, the one marked with the blue, you can see that there is a oral polyp. Oral polyp is basically a smooth mass of edematous and inflamed mucosa which has protruded through the perforation in the tympanic membrane and is now presenting in the external auditory canal. So this is an oral polyp, and you can see how rest of the tympanic membrane is having granulation tissue all over. So oral polyp and granulation tissue is also another pathological change you notice over here. Next is a cholesterol granuloma, which are basically some focal areas of cholesterol granuloma formation can happen, and microscopically it consists of a giant cell reaction surrounding the cholesterol clefts. However, this is not very common in this type. It is more commonly seen in the atticoantral type or the squamosal type. Next is ossicular chain. Now, it is very important to check the status of the ossicular chain whenever there is a perforation. Through that, you check the middle ear for the status of the ossicular chain, because this disease is often associated with some destruction of the ossicular chain. And affected ossicles will show an area of hyperemia with proliferation of capillaries and prominent granulation tissue. Now, this brings in a question as to what is the most common ossicle or part of ossicle which is involved in ossicular chain necrosis or destruction in chronic otitis media. The most common one is the long process of incus, and following in decreasing order of frequency, next is the stapes crura, next is body of incus, and then manubrium of malleus. In the image over here, you can see that there is an eroded long process of incus, and you can see the stapes over here. So these are all the pathological changes you see in the active mucosal type. Now coming on to the third type, which is the healed chronic otitis media. Now here there are two different things that can happen. First is tympanosclerosis. Now what is tympanosclerosis? I already showed you a picture before that these are basically these white chalky deposits that you see that the tympanic membrane heals with. What are these white chalky deposits? Is basically hyalinization and subsequent calcification of the subepithelial connective tissue. This is seen on remnants of the tympanic membrane or under the mucosa of the middle ear. And the common sites include the promontory, ossicles, joints, tendons, oval and round window. This can interfere with the mobility of these structures and cause conductive deafness. So that is one of the pathological changes you see. The other one is the presence of fibrosis and adhesions. This is also a result of the healing process. Here you basically see scarring on the tympanic membrane, and if this involves anywhere near the ossicular chain, it can actually impair its mobility as well, or even cause blockage of the eustachian tube. You can see in the image over here that the healing has happened by scarring of the tissue. This does not look like a normal tympanic membrane at all. These are all the pathological changes of the mucosal type. Now we'll discuss about what are the clinical features that you see in a patient. The most common one is the patient presenting to you with a discharge from the ear. Now, what are the characteristics of this discharge? This discharge is usually mucoid or mucopurulent type. Mucoid is basically when the middle ear mucosa gets involved, and that leads to a mucoid type of discharge. If there is a secondary infection of a bacteria involved, then it leads to a mucopurulent discharge. And this discharge is not foul smelling and not blood stained. This is very, very important because this helps you in differentiating from the other type, which is the squamosal type. The discharge can be constant or intermittent, and most commonly you will see that the discharge occurs or even increases at the time of any upper respiratory tract infection or an accidental entry of the water into the ear, most commonly when swimming, or it can even happen during bathing. Sometimes small amount of discharge dry up at the medial end of the external auditory canal, and it leads to some crust formation. So it is very important when you examine the patient, you should definitely first clear your field and then look into the ear properly and see if there is a perforation beyond that. Sometimes a crust formation can actually impair your view towards the tympanic membrane, and you'll probably end up missing a perforation of the tympanic membrane. Now coming to the clinical features, second is hearing loss. Now in this case, hearing loss is usually of the conductive type. However, in some situations you can also see that there is a sensory neural element involved, and that is mostly in cases, long-standing cases, where even the cochlea can suffer some damage due to toxin absorption from the oval window and the round window. In that case, you see that the hearing loss becomes the mixed type, but most commonly it is the conductive type. Now, the degree of the hearing loss that the patient will suffer from depends on a number of factors, like what is the size of the tympanic membrane perforation, where is it located, is there any ossicular chain disruption, and what is the status of the inner ear. And there's another very important phenomena you see in these cases is that sometimes the patient will come to you with a paradoxical effect, meaning the patient may actually come and tell you that they are able to hear better in the presence of discharge rather than when their ear is dry. And how do you explain this? This can be explained by a phenomena which is known as the round window shielding effect. What happens here is that the discharge that is getting produced, it actually helps to maintain the phase differential between the oval and round window, which is very important for the conduction of sound. If you know this physiology of sound conduction, you'll know that maintaining a phase differential between the oval and round window is very essential. So what the discharge is doing here is that it is helping in maintain the phase differential, and hence it improves the hearing. Whereas when the ear is dry with a perforation and there is no discharge present, the sound waves end up striking both the oval and round window at the same time, and thus they end up cancelling each other. So the phase differential is lost over here, and in this case you see a greater hearing loss. So this is a very paradoxical effect that you see, and this is a very common thing you can be asked in your Viva as well if you get a case of CSOM. Next is perforation. Now we have to understand what kind of perforations can we see. So the perforation in this type, mucosal type, is always a central perforation, and the position of it is either anterior, posterior or inferior to the handle of malleus. You see in the image over here, this is the handle of malleus. It will be either anterior, posterior or inferior to the handle of malleus. Coming to the size of it, it can either be small, medium, large or even extending up to the annulus, which is then known as subtotal perforation. So if you see, these are images you draw when you see the patient. This is how you will depict a small, medium, large and subtotal perforation. In the first image over here, you can see that this is a small central perforation involving the anterosuperior quadrant. This one is a medium central perforation in the anterosuperior and anteroinferior quadrant. Third image over here is a large central perforation, which is of a kidney-shaped perforation, and you can see that this is involving three quadrants: the anterosuperior, anteroinferior and posteroinferior quadrants. Last of all is the subtotal perforation, where the perforation is huge and it is extending up to the annulus. However, the tympanic annulus is still intact. So these are the different sizes of perforation that you can notice. And there can be different shapes like round, oval or kidney shaped. Next, coming to middle ear mucosa. What are you going to see here? So because this middle ear mucosa will only be visible whenever the perforation is quite large, that you are able to see through it inside the middle ear. When it is inflamed, it will look very red, edematous, velvety and swollen. You can see in the first image over here, the middle ear mucosa looks to be very reddish and velvety, very edematous. Occasionally you may also see a polyp. I have already shown the image. There is an image over here which is showing an oral polyp, and the structures that you will be able to see through a large perforation in the middle ear would be the oval window, round window niche, eustachian tube orifice if it is really large, very large perforation, parts of the ossicular chain and the stapedius tendon. Other than this, the other features you will be seeing or on examination would include tympanosclerosis, which are white chalky deposits, ossicular chain necrosis, the most common being the long process of incus, or rather the lenticular process of the long process of incus. And lastly, you can also see fibrosis, adhesions and scarring in the tympanic membrane. When you perform tuning fork tests, the Rinne's test will come to be negative on the site of the disease, Weber's test will be lateralized to the diseased ear, and the absolute bone conduction test would be normal. So these are all the symptoms and signs you will be seeing when a patient of mucosal chronic otitis media comes to you. Next, we'll talk about how will we investigate a patient of mucosal chronic otitis media. First of all, the most important thing you need to do is examination under microscope. You have to do this on a priority basis for all cases. This will help you in checking the tympanic membrane perforation, if there is any presence of granulation, oral polyps, if there is any ingrowth of squamous epithelium, if the ossicular chain is intact or has it been disrupted, if there is any tympanosclerosis, adhesions, etc. You can also use this to collect the pus from the middle ear and send it for culture sensitivity. So this is very important for all cases. Second, you have to perform a pure tone audiometry, and this will help you in finding out the degree and the type of hearing loss. And this will also help you in counseling of the patient preoperatively, so that they understand what would be the outcome after the surgery. Usually we see a conductive type of hearing loss, but it can also have a sensorineural component in some cases. Third is the culture and sensitivity of the ear discharge. This will help you in selecting the right antibiotic drops. And fourth, a very important one, especially in cases of surgery, would be an X-ray mastoid or a CT scan of the temporal bone. We do prefer the CT scan of the temporal bone. Usually in findings, you'll see that the mastoid is sclerotic, but it may also be pneumatized with a clouding of the air cells. And very, very important to know is that there will be no evidence of bony destruction, because the moment you find any evidence of bone destruction, that becomes a feature of the atticoantral disease or the squamosal type. In that case, the disease will no longer be the mucosal type. So these are the 4 investigations that are important. Next, we talk about treatment of the mucosal type. Now, the aim of the treatment here is, first of all, my aim is to control the infection in the ear of the patient and eliminate all the ear discharge. And once that has happened, my second aim would be to correct the hearing loss surgically. So first, we'll have to talk about the conservative medical management before we move on to surgical management. So first, you'll have to do oral toileting, where we remove all the discharge and debris from the external auditory canal. You can do it by either dry mopping with a sterile cotton swab, or you can do a suction clearance under the microscope. So that will clear off all the discharge and debris. Second, you prescribe topical antibiotic ear drops. It can be a combination of antibiotic and steroids as well. Usually it is given 3 to 4 times a day, and this has a local antimicrobial and anti-inflammatory effects. The most preferred group of antibiotics here is the quinolones group. Amongst them, we usually use the ciprofloxacin or the ofloxacin drops, and among steroids, we usually give a dexamethasone drop if required. It is very important to remember that we will not give any ototoxic antibiotics over here. The ototoxic antibiotics are the aminoglycosides, so we will definitely be avoiding them. Next is a systemic antibiotic. Usually this is prescribed only in cases of acute exacerbation, and this has no role to play in treating any uncomplicated cases. Next, we also advise some basic precautions to be taken by the patient, like the water should not be entering the ear while they are bathing or swimming, so they can use some earplugs or rubber inserts while bathing and swimming. Second, should avoid blowing the nose very hard, because when you blow the nose hard, what it can do is it can push the infection from nasopharynx, if there is any, to the middle ear, and that will exacerbate the situation. And also, the patient should avoid self-cleaning the ear, because they constantly might feel that there is some discharge, some irritation, or some itching happening in the ear, and hence they should not do that. Next is treatment of contributory causes. Contributory causes can include like infection of tonsils, adenoids, nose and paranasal sinuses, any allergy. So it is also important to treat all these contributory causes. Next, we come to the main part, which is the surgical part. Now in surgery, what we do is a tympanoplasty. Tympanoplasty is done in cases that do not become active on medical management, and in this case, what we have to do, surgery is required to heal the tympanic membrane perforation. And inactive cases should also have the closure of tympanic membrane perforation to prevent the recurrence of any activity, together with ossicular reconstruction if required. So basically we are performing a restoring of the hearing mechanism by repairing the tympanic membrane perforation, and also if there is any need for ossicular chain reconstruction, we also perform that. Secondly, if there is any oral polyp or granulation tissue, we should remove it before giving any local treatment with antibiotics. Also, a very important fact to remember here is that an oral polyp should never be avulsed, because you never know where the oral polyp is actually attached to, because you'll not be able to see beyond it. So you should just assume that what if it is arising from the stapes or the facial nerve or the horizontal canal. So if you end up avulsing the oral polyp, it can lead to more complications, which can be facial paralysis or even labyrinthitis, which are difficult complications to deal with. So this is all about the treatment aspect of mucosal disease. This completes everything about mucosal disease. Next, we'll talk about squamosal type of chronic otitis media. Now, coming to squamosal type of chronic otitis media. This was the type that was earlier described as the Atticoantral type, also known as the unsafe or dangerous type. And why would it be called dangerous type? Because of the bone eroding properties of cholesteatoma that we see in this type, and there is a huge risk of serious complications developing. That is why this type used to be termed as the dangerous type of chronic otitis media. Now, squamosal disease involves the posterior-superior part of the middle ear cleft, which includes the attic, antrum, posterior tympanum, and the mastoid. Now, we'll discuss about the types of squamosal disease. So, it can be divided into inactive and active types. Now, inactive squamosal chronic otitis media is also known as retraction. Here, what we see is there is either a retraction of the pars flaccida or the pars tensa, usually in the posterior superior part, which has the potential to become active with retained debris. You can see in the first image over here that this is the attic. You can see how there is the presence of a retraction pocket in the attic region. And this is usually clear of any discharge or debris. However, it always retains the potential to become active and start to form debris and collection of it inside it. The second type is the active squamosal chronic otitis media, which is also basically known as the cholesteatoma. Here, we see a presence of retraction of pars flaccida or pars tensa in the posterior superior part that has retained squamous epithelial debris, and it is associated with inflammation and production of pus from the adjacent mucosa. If you see in the right image over here, we can see the presence of cholesteatoma, pearly white cholesteatoma flakes in the attic region. So these are the two types of squamosal type of chronic otitis media. And now that we are talking about cholesteatoma, I will be making a separate video about cholesteatoma, the different theories, the different types, etc. But the first thing you need to know about cholesteatoma is, what is cholesteatoma? That's a very common question that you are asked. And it is defined as a sac of keratinizing squamous epithelium containing desquamated epithelium in the middle ear cleft with bone eroding property and which has lost its self-cleaning capacity. So this is the definition of cholesteatoma. In other words, cholesteatoma is the presence of skin in the wrong place. Whenever there is a presence of skin in the middle ear, it is described as cholesteatoma. Now, for the rest of it, please check out my other video on cholesteatoma. Now we'll discuss about the etiology of squamosal type. Now, here most commonly what happens is otitis media with effusion predisposes to chronic retraction of the pars tensa or flaccida, and this happens because of the formation of a negative middle ear pressure. As a result of this, the pars tensa or the pars flaccida gets retracted chronically, and this subsequently progresses to formation of cholesteatoma. Second, children who have persistent or refractory middle ear disease and who require multiple ventilation tubes are also seen to be at increased risk of disease. Third cause is the presence of congenital cell rests. This is usually the cause for congenital cholesteatoma. And there are various theories for acquired cholesteatoma, like Whitmak's theory, Rudy's theory, Haberman's theory, Sade's theory. These are all things I'll discuss in a separate video. Now, coming to microorganisms involved in squamosal disease, these are almost the same as the tubotympanic type or the mucosal type. These include Pseudomonas aeruginosa, Streptococcus, Proteus, E. coli, Bacteroides, Peptococcus, and Fusobacterium. Now we'll discuss about what are the pathological changes we see in both the types of squamosal chronic otitis media. So in the inactive squamosal type, there are two changes that we see. First is retraction pocket. Now retraction pocket, as I have said, it forms because of the presence of a negative middle ear pressure. Now what is a retraction pocket? It is basically an invagination into the middle ear space of a part of the tympanic membrane, and this can either be fixed or free. Fixed meaning when it gets adherent to the other structures present in the middle ear, or free when it can move medially or laterally depending on the state of inflation of the middle ear. You can see in the image over here, this is a retraction pocket in the attic region. Second pathological change is epidermalization, which is basically a more advanced type of retraction seen. This refers to replacement of the middle ear mucosa by keratinizing squamous epithelium without retention of keratin debris. Next, coming to active squamosal chronic otitis media. The pathological changes here include the first being cholesteatoma. So basically what we are seeing here is a benign keratinizing epithelial lined cystic structure found in the middle ear and mastoid. And this cholesteatoma can cause destruction of local structures like the ossicular chain or the otic capsule, and that is what leads to complications, and hence that is why it is used to be known as the dangerous type of CSOM. So this is first is about cholesteatoma. Second is osteitis and granulation tissue. So what is osteitis? Here there is an inflammation of the ostium. Basically osteitis involves the outer attic wall. Basically the bone is inflamed over here. So the regions that are involved here are the outer attic wall and the posterior superior margin of the tympanic ring. Secondly, you can find a mass of granulation tissue surrounding the area of osteitis, and which can eventually fill up the attic antrum, posterior tympanum, and the mastoid. You can see in the image over here, we can see a fleshy red polyp-like structure that is coming out from the attic, and it can fill up the meatus as well. Third change is ossicular necrosis. Here, this is very common feature of squamosal type, and this can also be seen in the tubotympanic type or the mucosal type, but it is rarer over there. And destruction may be limited to the long process of incus, or it can also involve the stapes suprastructure, handle of malleus, or entire ossicular chain. Another little viva question that you need to know is, what is a cholesteatoma hearer? What does that term mean? This term means that sometimes what happens is the cholesteatoma can actually bridge the gap that has been caused by the destroyed ossicles, and when it bridges the gap, what happens is the hearing loss disappears. So you can actually paradoxically see that in these cases the patients will be actually not having much of a hearing loss. However, they do have damage to the ossicular chain. So these patients are known as cholesteatoma hearer. You can see in the image over here that there is an eroded long process of incus, and we can see the stapes. Next is a formation of cholesterol granuloma. Now what is cholesterol granuloma? It is basically the formation of granulation tissue with foreign body giant cells surrounding the cholesterol crystals. This happens as a reaction to the long-standing retention of secretions or hemorrhage, and it may or may not coexist with the cholesteatoma. You can see in the image over here, this is the cholesterol granuloma formation. Now when this cholesterol granuloma is present behind an intact tympanic membrane in the mesotympanum, it can appear as a bluish structure. So these are all the pathological changes you see in squamosal type of chronic otitis media or the atticoantral type. Now we'll discuss the clinical features of the atticoantral type. First, coming to symptoms, the most common one is ear discharge. Now let's discuss what are the features of the ear discharge. Now, it has a very characteristic feature. The patient will have a persistent foul smelling, maybe blood stained, purulent discharge coming from the ear. So you can see how this is very different from the tubotympanic type. Why do we see a foul smell over here? Two reasons. First is because of the bone erosion happening. Second is due to the infection by saprophytic bacteria and anaerobes. Next, why do we see this discharge to be blood stained? It will be blood stained whenever there is osteitis and granulation tissue present. That will lead to a blood stained discharge. Now, in this case, discharge is scanty in amount compared to profuse or abundant in case of tubotympanic type. So scanty that even a patient might not be aware of it. And any cases when the patient comes to you where a continuously discharging ear, but then the patient suddenly says that there is no discharge coming from the ear, do not assume it to be actually a good indication, because it is a very ominous sign. Perforation, what happens over here is that the perforation might actually get sealed by the crusted discharge or any mucosa or any polyp. So basically there is an obstruction to the free flow of discharge happening. When there is an obstruction, the patient will come to you with the fact that, hey, that I used to have a lot of discharge coming from the ear and suddenly it has disappeared. But what you will not be able to know from the history, but only find out when you examine the patient, that there is actually an obstruction to the free flow of discharge. Now, when this obstruction persists, it can actually has the potential to result in all the complications of CSOM. So, a cessation of discharge in a continuously discharging ear is a very ominous sign. This is very important for you to remember. Next is the discharge is usually continuous in these cases due to the presence of osteitis. So these are all the features of ear discharge in an atticoantral type. Next, coming to hearing loss, the patient will usually be it's almost the same as tubotympanic type. Hearing loss is mostly conductive, but you can have a sensory neural element. And as I've said, in a cholesteatoma hearer, if the cholesteatoma ends up bridging the gap between the ossicular chain disruption, it can actually lead to normal hearing. Third, the patient can also complain of bleeding from ear due to the presence of granulation tissue or polyp while cleaning. The patient can have tinnitus, or patients can have n number of other symptoms which indicate a complication rather than the presence of uncomplicated atticoantral disease. And these include pain, vertigo, facial palsy, headache, vomiting, convulsions, ataxia, fever, etc. I'll discuss about the complications of CSOM in a separate video. Next, we'll discuss the signs that we see when we examine the patient. First of all, there is a perforation of the tympanic membrane. But however, the perforation here will be very different from the tubotympanic type, where mostly you will see a central type of perforation. Here, you will be seeing either a perforation in the attic or the posterior superior margin. The first image over here shows an attic perforation, and the second image over here shows a posterior superior marginal perforation. Sometimes you can even end up missing a small attic perforation because of the presence of small amount of crusted discharge over it, and it can also be masked by any small granuloma. So that is why it is important that you perform the examination under the microscope for all these patients. Second is we'll see a retraction pocket. Now, retraction pocket is a whole new different discussion. There are two classifications that you need to know, the Toss and Sade's classification for pars flaccida and pars tensa retraction. I'll be discussing this in a separate video. But just to show what it looks like, basically retraction pocket is an invagination of the tympanic membrane, which we'll see in the attic or the posterior superior area of pars tensa. And the degree of retraction will vary according to the case. In early stages, these retraction pockets are shallow and self-cleansing. But however, later if the pocket starts to become deep, it will start accumulating keratin tissue and gets infected. So these are the Toss and Sade classification. The first one is the Toss classification for pars flaccida retraction. You can see in the first image over here, which is stage 1. Here the tympanic membrane, you have to look at the pars flaccida. Here the tympanic membrane is mildly retracted and it is not touching the malleus. Second, in the stage 2, you'll be seeing that the tympanic membrane is retracted and it is adherent to the neck of the malleus. Third stage will show a partial erosion of scutum, and the fourth stage will show a complete erosion of scutum. So these are the 4 stages in Toss classification of pars flaccida retraction. Now coming to Sade's classification of pars tensa retraction, in the first stage over here you can see that it is a very mildly retracted tympanic membrane and is not in contact with any middle ear structure. Second stage you can see that there is a retracted tympanic membrane which is in contact with the long process of incus. In stage 3 you'll see this stage 3 is known as middle ear atelectasis, and in this case what we see here is a retracted tympanic membrane in contact with the promontory. You can see over here that the promontory is very visible. It is in contact with the promontory, but it moves on cecalization. And the fourth stage is also known as adhesive otitis media. And in this case you'll see that the tympanic membrane is quite plastered to the promontory and there will be no movement of cecalization. So these are the two classifications of retraction of the tympanic membrane. The third finding over here is seeing cholesteatoma. What we see, how does it look like? It looks like pearly white flakes which can be seen in the retraction pockets. You can see the image over here. They look pearly white flaky like structure, and the most common sites are either the attic or the posterior superior region. However, this is what I describe acquired cholesteatoma as. Congenital cholesteatoma, however, looks very different and it appears like a pearl-like mass behind an intact tympanic membrane. Other than this, the other features that I've already discussed in pathology section are osteitis and granulation tissue, ossicular necrosis, cholesterol, granuloma. So these are all the symptoms that these are all the signs that you'll be seeing when you examine the patient. And when you perform the tuning fork test, you'll see that the Rennie's test will be negative, Weber's will be lateralized to the diseased ear, and absolute bone conduction will be normal. Next, we come on to investigations. These are very similar to that of tubotympanic type, where first, in all cases, you have to perform an examination under microscope to confirm the diagnosis, to suction clear the ear, and while doing this, it will help you in understanding if there is any cholesteatoma present. If it is present, where is it present and the extent of it. If there is any evidence of bone destruction, granuloma formation, what is the ossicular chain status. All of those information can be gotten from here. Second is the pure tone audiometry, which will confirm the type and the degree of hearing loss, and this will again help you in preoperative evaluation and also in counseling the patient about the surgical outcomes. Usually we see a conductive type, but there can also be a sensory neural component over here. Next, we can, in case of a continuously discharging ear, we can perform a culture and sensitivity of the ear discharge. And last of all is performing an X-ray mastoid or a CT scan of the temporal bone. We prefer a CT scan of the temporal bone nowadays. This will help you in indicating what is the extent of bone destruction that you're gonna see here and what is the degree of mastoid pneumatization. It will also help you in finding whether if there is any presence of a low-lying dura or anteriorly placed sigmoid sinus when you are planning surgery for a sclerotic mastoid. That will caution you towards being careful when you approach those particular areas. Now, what does cholesteatoma look like in a CT scan? It will be seen as a soft tissue mass with a homogeneous opacity. You can see in the image over here, the yellow marked over here in the first image, you can see that this is what a cholesteatoma looks like. Here it is present in the Prusac space. And cholesteatoma can lead to destruction of the attic antrum, and in that case it will be better seen on a lateral view. Now, what is the earliest sign that you will be seeing in radiology over here? That is blunting of scutum. If you see in the second image over here, on the left side where the yellow arrow is present, you can see the presence of scutum, which is looking like a sharp tip. Whereas on the right side, the scutum is actually not looking like a sharp tip anymore, it has been eroded. Other than this, you can see erosion of ossicles, lateral wall of attic, tegmen, sigmoid sinus plate, posterior superior canal wall, facial canal, and labyrinth. And mastoid is usually sclerotic in these cases. Coming to the last part of the discussion today, we'll discuss the treatment of Atticoantral disease. So here there is no role of conservative treatment at all. We'll discuss in what cases we can use conservative treatment, but first let's discuss the mainstay of treatment, which is surgery. Now, the aim of the surgery is over here two things. First would be to eradicate the disease and make the middle ear safe. You have to remember this term. You have to make the you have to make the ear safe. This is very, very important. Now, once this aim has been achieved, the second aim would be to reconstruct the hearing mechanism. Now, there are two different ways to do it. There are procedures which are known as canal wall down procedures, and then there are procedures known as canal wall up. Now, first we'll discuss a little about the canal wall down procedures. Here what we do is basically we open up the mastoid cavity into the external auditory canal. So we are basically trying to convert it into a single cavity so that the diseased area gets fully exteriorized. Now, what are some common operations that come under this? The various canal wall down procedures are: one, it can be an atticotomy. We perform an atticotomy when a cholesteatoma is limited to the epitympanic or attic region only. Second is known as atticoantrostomy, which is also known as Bondi's mastoidectomy. This is a type of modified radical mastoidectomy which we perform only for primary acquired cholesteatoma which have a perforation of the pars flaccida and an intact pars tensa, and the disease is limited to attic and antrum and not involving the middle ear space. The third type is a modified radical mastoidectomy. Now, modified radical mastoidectomy is basically a modification of the earlier surgery known as radical mastoidectomy, where we try to preserve much of the hearing mechanism as possible. That is, we try to retain the remnants of tympanic membrane, ossicles as much as possible, and the disease process is often localized to the attic and antrum. So this disease is removed and the whole area is exteriorized into the external auditory canal by removing the posterior meatal and lateral attic walls. The fourth option is a radical mastoidectomy, which is rarely performed nowadays. This is an operation where you eradicate disease from middle ear and mastoid without any reconstruction of the hearing mechanism. You remove the posterior meatal wall, and entire area of the middle ear, attic, antrum and mastoid is converted into a single cavity. And here we remove all the remnants of tympanic membrane and ossicles except for the stapes footplate, and periostal lining is also removed with obliteration of the eustachian tube with a piece of muscle or cartilage. So these are the four different types of canal wall down procedures that are commonly performed, and I'll be discussing each of them in separate videos more in details, but this is just to give you an overview of the different options that you have. Next comes the canal wall up procedure. Here what we do is we try to remove the disease by a combined approach through both the external auditory canal and the mastoid, but we try to keep the posterior bony meatal wall intact. So basically what we are trying to do here is we are trying to avoid a single mastoid open mastoid cavity. We try to approach the ear both through the mastoid as well as the external auditory canal. So in the combined approach or intact canal wall mastoidectomy, the disease is removed both permeatally and through cortical mastoidectomy, and posterior tympanotomy approach, in which a window is created between the mastoid and middle ear through the facial recess to reach sinus tympani. So these here you also need to know about the differences between canal wall up and canal wall down procedures, which again I'll be discussing in a separate video. Please do catch it over there. Other than this mainstay surgical treatment, the second is, after the ear has been made safe, reconstructive surgery needs to be performed. Hearing is usually restored by tympanoplasty, and this can be either done at the time of surgery or as a second stage procedure, depending on the patient or the case itself. What you prefer, if you want to give it some more time to check for recurrence of the disease, and if you also have to see that whether the patient is likely to come back for a second stage surgery also or not. Last of all is a conservative treatment. This is very limited in the management of cholesteatoma. You can try it in very selected cases if you see that the cholesteatoma is very small and easily accessible by suction clearance under the microscope. So in that case, you perform repeated suction clearance and keep on periodically checking the ear if it is remaining the same or not. And a few indications of conservative treatment would be in elderly patients above the age of 65 years, where the general fitness is not good, patients who are unfit for general anesthesia, or in patients who refuse surgery. In these cases, if there is any polyp and granulation tissue, you can surgically remove it by cup forceps or even cauterize it by chemical agents like silvanitrile. So that completes our discussion today on chronic suppurative otitis media, also known as chronic otitis media today. If you have any questions, please note them down in the comment section and I'll get back to you. Thank you.